Good evening, everyone. We are about to get started here. It looks like a few people are still logging on. So welcome, fellow snorers, sleep apneics, and upper airway resistonians, as we refer to them in my practice here, to webinar number 4 in our 6-part series. We're glad to be a part of your evening tonight, and we appreciate you guys spending some time with us. We want to give a shout out to Keller Lab, who is doing this with us. As you know, they're a full service lab. Many of you use them, and if you don't, we encourage you to use them. And they certainly are dedicated to helping you get going in all phases of dentistry, but especially in dental sleep medicine.
Also like to take a moment and talk about what we do. We've spent the last 3 webinars kind of getting people involved, dentists educated, and try to get you going in this area of dentistry. Well, that's pretty much what we do at Dental Sleep Solutions. We have the only turnkey solution run by dentists who are actually out here doing this for the last 20 years themselves, who have come up with systems. And if you really just, say, this is something I really want to get involved in, I don't want to recreate the wheel, I really know for sure that Rich and I can help you get going in your own area and be the go-to dentist in your area. And that's what we want. We want more dentists involved in this, and we're here to help you. So if you're interested in that, make sure you send us an email. We'll give you our contact information at the end of the webinar. Here's who we are. As again, Rich and I have been doing this for 20 years. You can read it yourself. Suffice it to say, I think we have as much experience as anybody around doing this. We're out here doing it ourselves every day. I have 3 dental offices. I just do sleep apnea. And Rich has been dedicated to doing just sleep apnea and snoring treatments for the past 10 years. So between us, about 20 years plus doing this. And I think most of your questions we can answer. We can help you get going. You want to go over the rest of the webinar series, Rich?
Yes, when we put this together, we had 6 webinars in total, and we're working on doing other types of educational things that we'll bring to your attention later. But the next one is October 12th, where we're going to talk about titrating the dental devices themselves and managing side effects. And the last one on November 9th is we'll deal with marketing and specifically with some gems that we can throw your way about how to bill for these things and get paid for them through medical insurance. So remember, if you're signed up, you're already signed up for these other ones. And we welcome those of you back who have been with us and welcome the new people as well.
And by the way, if you missed any of the first 3, you can review them at Keller. Lab.com. We should have that up on our website in the near future as well, but go to www.kellerlab.com and you can see the previous webinars if you happen to miss those.
Yeah, we also want to tell you about the in-person course that we're doing October 7th. It's a Friday in San Antonio. It's finally starting to cool off here about that time, and it's a great city to come to. I don't know of anybody else that's given you a full day of continuing education for $95, and we'll spend the first half of the day talking about dental sleep medicine basics, and the second half we're going to spend talking about how to implement this into your practice. We think it'll be a day well spent, and we encourage you to register at info@dentalsleepsolutions.com, and the people at Keller can help you get registered for that as well.
A little house cleaning here. Make sure if you want your CE credit for this webinar that when you receive an email from Dental Sleep Solutions, it'll be sent to your email address that you registered with. You must correctly complete a 10-question quiz within 7 days of receiving the email. Click on the link on the email, enter the required information, and then complete the quiz. You'll need your AGD member ID if you're not a member, and then put NA. It's important to do that if you, in fact, want your 1-hour CE credit for attending this webinar.
Thanks, Guy. Let's go over quickly. Let's jump in here and get started. Learning objectives for today. I think it's important that we know what we're treating, and we're going to talk about that. We'll refresh you on the American Academy of Sleep Medicine practice parameters. we throw a lot of acronyms around here, and sleep disordered breathing, SDB, diagnosis, who, what, where, when, how, etc. We'll talk about home sleep testing versus in lab or polysomnogram, and then we'll talk about the treatment recommendations for each one of these different diagnoses.
What are you treating? How do you know? Treatment without testing is risky. I mean, these are all questions that come at us all the time, Rich. I mean, when we answer emails and teach courses, I think it's one of the important subjects that we're addressing tonight.
Absolutely. If you don't know what you're treating, I mean, you've been a dentist a long time, and you know that tooth's got a big cavity, and you just open it up. You know at some point you're going to get to the bottom of the cavity, etc. But it's sure nice to have some tools in your bag. It's nice to have an X-ray, and it's nice to have some pull testing things and things like that. So we just have a different set of tools in our bag. And I've not heard of anybody getting sued out there, but I think we always need to be careful in this society today. So we want to be safe, and we want to keep our patient's best interest at heart. And if we do that, we won't get too far off track. So, Guy, why don't you go ahead and talk about this this flow sheet, because most all of the questions that we get center around, well, when a patient comes in and they have this or they don't have that, and this flow sheet is kind of an overview of how we treat these people.
Yeah, and it may look kind of overwhelming when you first look at it, but it really isn't. What Rich said is highly important. We don't do root canals on teeth without knowing whether they're abscess and taking X-rays. And we certainly shouldn't be treating people with airway problems unless we know what's wrong with them. So you're going to get people in your office, and the first question to ask or to understand is do you have a diagnosis or not? So PSG or prior diagnosis, things are changing, as we'll get into in a little bit, between PSG, which is the polysomnograph, in case you forgot. That's the full sleep test in a sleep lab, and there's also home sleep testing, which we'll talk about. But bottom line is, do they have a diagnosis by a physician? As a physician said, they either don't have apnea, which the diagnosis might be primary snoring in that case, or they may have a diagnosis of upper airway resistance or obstructive sleep apnea. So that's the first question. Have they had a test or not? As you can see, as you go off to the right, if they've had a test, these are the best patients oftentimes, because they've already had a test. They want treatment, and oftentimes maybe they've already tried CPAP and not compliant. So they've had a test, then what is the diagnosis? Well, if they're not severe, in other words, snoring, upper airway resistance, mild or moderate apnea, then we're going to consider doing an oral appliance with them. They could also have a CPAP, but an oral appliance should be right on the first line of what we would consider doing. We discuss with them which oral appliance is appropriate, take impressions, adjust the oral appliance. That's what we call titrating. When our symptoms seem to be alleviated, we do some home testing, maybe some further titration. And then when we're finished, they should be referred to the MD for further evaluation, maybe a PSG, and oftentimes that's recommended with their oral appliance in place. And then they should be placed on a yearly recall. If a patient has severe OSA, or maybe even moderate OSA with a lot of what we call comorbidity, they should really try CPAP first, and that's what the practice parameters from the American Academy of Sleep Medicine recommend, and Rich and I both agree that that's the appropriate treatment. If they happen to fail CPAP, can't wear the CPAP, in other words, then we're back into the oral appliance route and the same things we just discussed. If you look over to the left side of the screen as you're looking at it, if they have not had a diagnosis, then we've got to get a diagnosis. We can refer them to the MD. We'll talk about how we get a diagnosis with either a PSG, polysomnograph, or a home sleep test, HST. And once we get a diagnosis, then they're basically back over to the right side of the screen. We'll go in a little bit more detail about some of these things, but this is important to remember. We don't want to just jump down to oral appliance without going through a diagnosis or understanding what we have.
Very, very good, Guy. Did a great job explaining that. And as you all should be aware of this, the American Academy of Sleep Medicine put out their practice parameters in the February of 2006 issue of Sleep. And we encourage you to refer to that, especially when you're talking to your physician colleagues. And that is basically that there's enough research out there that says we can use these dental devices to treat people who are mild to moderate as a first line of therapy and for people who fail CPAP. And we like to adhere to those types of guidelines. I think that in some ways, as dentists, we can be a little bit roguish, if that's the right word, and go out there and instigate some of this stuff and do this. And we'll talk about why, as dentists, we're in a position to do that. But for the most part, we need to be doing this with our physician colleagues, and we can't drive that point home enough.
Some key points, Rich, that I think we should pull out of the practice parameters or note is that judgment regarding treatment must be made by a physician. I think you said that, but I want to make sure that's clear. We can't make the diagnosis. We have to have physicians to make the diagnosis. We're kind of tied together with them likely forever in this area of dentistry and medicine. So they need to make the diagnosis. We need to make the oral appliance, airway dilating appliances, whatever we want to call them, and then get them back to the physicians. We need to work closely with them in this regard. Patients should return for follow-up visits to the clinicians and also oftentimes having a sleep study by them. Also, we should see them annually as well. So again, I think some of the key points with that practice parameter, because there's more to it than just what we put on the screen previously. It's about a page or two long. Basically, it says that we need to work closely with the physicians and we need to have some advanced training in dental sleep medicine to be doing this.
Now let's talk about, and again, the title of this is protocols for how you do this. So we're trying to give you all out there some sidelines. I like the football field analogy. We're going to kind of present this going down the middle of the field, but remember, there's a left hash mark and a right hash mark, and then there's a left sideline and a right sideline. We want to stay within the hash marks for the most part, but we can go all the way out to the sideline. So when we talk about this, just kind of think of that analogy and keep that in mind. But when we look at treating snoring, we're basically treating very mild people. Now, you can make an argument that, aren't you kind of making a diagnosis by exclusion if you do this? Yeah, in some ways you probably are. But when you look at this and you think these people are basically younger and they're healthier, they don't have heart problems. They don't have a history of their spouse telling them, man, he stops breathing, every 5 seconds, and I'm just worried he's going to die. They're not sleepy. They're not tired during the day. The ESS, remember, is the Epworth Sleepiness Scale, and that's their own evaluation of how well they sleep, and that being below 10. Their BMI, remember, is body mass index, so they're not obese. Their neck size is smaller. If we do a home study, it's below a certain number, and we're still, on top of all of this, we're still coordinating all of this treatment with their physician. So these, again, are just guidelines for how we treat these types of people who are just snoring.
I think there is some controversy over, well, can we just say these people just snore, or do we need to send everybody in for a sleep test? And I don't know if there's a great answer to that. There's certainly pros and cons of each of them. If you want to be on the safe side, everybody gets either a home sleep test or a polysomnograph test by a physician, or at least scored and by a board certified physician. And that's the one extreme. That's the right wing, so to speak. If you want to go left wing, I think that there's also a good argument to be made. These people don't have any other symptoms. The chances of them getting a diagnosis of sleep apnea or upper airway resistance is very low, and treating them just for snoring if they fit this guidelines is acceptable in a lot of people's books. What snorers, Rich, are not acceptable should we start worrying about? And really, if you're going to take the side of maybe ruling out some people for just snoring, that these people really should have tests. People that snore in all positions, anyone who's sleepy, anybody has an Epworth Sleepiness Score above 10, the ESS, in other words, they're sleepy for a reason. So they need a sleep test. If it's not because of the apnea or upper airway resistance, we need to find out what it is. Certainly anybody whose spouse or significant other has noticed them quit breathing while they're asleep, anyone with cardiovascular disease in addition to snoring or some other comorbidities, diabetes would be another big red flag for me. And again, any cardiovascular disease, I think certainly a test with a board certified physician would be indicated in these snorers. Do you agree, Rich?
Absolutely. You put that very well. And our little tagline at the bottom there, sleepy snorers should be tested. I think you're going to have to figure out your own path and how you do this. But as a general guideline, sleepy snorers should be tested and just leave it at that. So we've got some idea about how people start to enter this treatment regimen. And most of the time it's just snoring. But sometimes they've been snoring for 20 years and they're sleepy and they're tired and all of those other things. So we know sleep apnea is kind of the new disease that's out there now. And that's good for us as dentists. We want to capture more of the market share, and we have some challenges in front of us in order to do that. The first of which is that we need to educate ourselves and we need to make sure that we're doing this the proper way.
One thing I want to mention before we get off the subject of snoring is I don't believe personally that snoring, even if they don't have upper airway resistance or apnea today, I think they're pre-apneic, very likely going to have it in their lifetime. We know this is a progressive disorder. It gets worse every year. There are some studies that show just snoring alone has an increased incidence of high blood pressure. And so I think treating a snoring for the sound and the annoyance to the bedtime partner is important, but I believe, and I think there's starting to be some evidence to show that treating snoring may slow down the progression or be a benefit health-wise other than just treating the snoring.
Good point.
Let's talk about managing your patient flow. And you have patients that are from your office, and then there are patients from the outside of the office. Okay, that's real obvious maybe, but it's a little different than your patients of record versus new patients. As you begin this journey into the dental sleep medicine world, the majority of your patients are going to come from within your own office. This is done by careful screening and testing. Eventually, as you start finding patients, it gives you an opportunity to network with physicians, other healthcare professionals, and the flow of patients from outside your office will gradually and with proper systems quickly start flowing from outside of your own office. And the patients are somewhat different even though you're treating the same disease process.
What kind of tests can we do if we suspect somebody has a problem? And clinical suspicion is where we start all of these types of things. And we need to understand that there is the polysomnogram or the PSG, as well as home sleep testing. When I got into this 10 years ago, Guy, home sleep testing was kind of an afterthought almost. And we were looking at maybe not. Where's it going to play into this? How's it going to play into this? Well, we know now that Medicare has come out with certain guidelines and rulings, and they've said that you can actually make a diagnosis from a home sleep test. We know within our franchise, Dental Sleep Solutions, we have negotiated discounts with not only the people who sell these home sleep testing devices, but with the services that go out there and read these things. So these are the tests that are available. Anytime we're in doubt about which particular test they should have, we should punt to their primary care physician, their internist, their cardiologist, and pulmonologist, and get some help with that. But as you feel more comfortable treating this and doing this, you'll play a bigger part in actually doing these types of tests and what's there. But for now, this is what's available, and these are our options.
I agree. I usually go over both options with the patient and sometimes have their input. But we get caught up in this as dentists. But the bottom line is we just want to test our patients. And that this isn't where our profit center is, and nor should it be. Our goal is to get them tested. And however we can do that, whatever serves the patient better is important on this. Diagnosing sleep disordered breathing. The number one thing, and most importantly, is we've got to have a suspicion. I think the guidelines are clear, in particular for home sleep testing, that we don't just go and test everybody that walks through the door. That's not the purpose of introducing home sleep testing into the medical world. Basically, the home sleep testing is brought about to make testing easier, but we should still only do it on people who we suspect that they may have a problem. This is done through their medical history, their physical history, to their anatomy. In other words, if you have retrognathia and large tongue, questionnaires, then we can do PSGs or portable sleep tests. I don't know, Rich, what do you feel about oximetry alone? I mean, it's easy. It's got some drawbacks. What are your thoughts on that?
Well, as far as a diagnostic tool, I don't think it's there yet. I do think that yes, somebody who really knew what they were doing could look at that. But the bottom line is, like you said, we want to involve our physician colleagues, and we want to ask questions and have questionnaires and things like that. And we really want to get our patients tested for the most part.
And currently, oximetry is not approved for diagnosing. Only polysomnograph and home sleep test level 3 scored by a board certified sleep physician are the two quote unquote legal, which means they've adhered to the American Academy of Sleep Medicine's practice parameters, and insurances will pay is the other big key on that.
If a dentist orders a sleep test in the middle of a forest, does anyone hear him? That's who knows, right? But as dentists, we need to know that we can order sleep tests. We see patients, and I think we have a slide coming up next too that talks about why as dentists, we should be the people, the professional who gets this whole thing started. But suffice it to say that as a dentist, you can order these sleep tests. We get them to the sleep lab or get them hooked up with a home sleep test. Hopefully there are some physicians in your community.
Yeah, I'd like to caution, though, there are some state laws. I'm in Florida, Rich is in Texas. In our states, we can do that. I do know that there are some other states that certain guidelines have to be met. So you do want to check with your state board about that. Also, patient's insurance sometimes might dictate who will pay for this. Sometimes the primary care has to order it and some things like that. But the bottom line is we should be involved in getting these people tested. I think that's what we really want to say here. And in most cases, we can refer them directly to a sleep physician or directly to a sleep lab. And in most areas, I know I can here in Florida. I know Rich can in Texas. But again, we just want to get these patients tested. And the next slide that Rich alluded to is we are truly in the best position to do this above any other healthcare practitioner. I mean, we spend more time with our patients than physicians do. Physicians don't see their patients as often as we do. And we have an opportunity to look, a slide doesn't say this, but in our patients' mouths, we're intimately involved with the patient's mouth. We see they have a big tongue. We understand craniofacial anatomy. And when you combine all those together, there's really no other healthcare provider who has a better opportunity to find these 85 to 90% of the people who are walking around with untreated OSA, an undiagnosed OSA, to bring them and get them tested. We're by far in the best position.
So do your homework, read up, be confident when you talk to your physician colleagues and as well as your patients, and let's get them headed in the right direction. So when we talk about, before we talked about treating snores, and we had some guidelines for what we treat and when we treat and don't and things like that. And now we talk about when do we actually cross a line and make that referral. So these are patients who have more comorbidities. They're patients who have heart problems. They're more obese. They're more sleepy. They have bigger necks. If we do home sleep testing on them and we use that quote as a screening tool, and in that particular instance, you might send somebody home with that, but not have that particular study interpreted or scored or read by a board certified sleep physician. You can do all of those things, and those are within those sidelines that we talked about earlier. But remember that sleeping snorers should be tested, as well as people who have witnessed apneas and they're just tired and they're more obese and they have more problems. And all of this makes sense intuitively.
It does. Just remember, if it's just snoring and you can't they don't have any other check marks, then we may be safe there. If they've had a home sleep test and it's they're not going below 90 and their RDI is less than 5 or 10, depending on how you feel about it.
And that brings up our next slide. When we talk about this, one of the caveats of doing home sleep testing and these types of things is that when you think about what I've heard guys say this before, and he talks about a PSG being a very accurate test of a poor night's sleep, and a home sleep test being a less accurate test of a typical night's sleep. So we have to keep those things in mind. And one of the things that we do not want to do is to test a patient and assume from that test that he does not have the disease, and therefore we don't treat him. So this is where the home sleep testing and false positives and false negatives and these types of things come in. So one of the guidelines that Medicare has laid down is that when patients do have certain comorbidities, and they do have a high clinical suspicion of having some kind of sleep disordered breathing, and we do a home sleep test on them, if that home sleep test is negative, then their guidelines mandate that that patient has a polysomnogram. And that makes sense when you think about false positives and false negatives. In that case, it would be a false negative. And again, the rationale is that we don't want to test someone and assume they don't have the disease and therefore not treat them when the reality is that they do. So
isn't a home sleep test more likely to give you false negatives than false positives?
Yeah, I think it is. I mean, when you look at that, these things are.
I think the whole point there is too, which is worse. If you get a false negative, that's worse than getting a false positive, because you get a false negative, you're going to neglect a disease process. So the false negatives are what we're really concerned about. It's hard to fake an apnea, and if you got the oxygen dropping down, unless there's some equipment malfunction, the false negatives are what we're concerned with. And again, I think that can't overemphasize that. If someone has a high pretest probability and you get a negative on a home sleep test, then the guideline is to have a full test, because there's something going on we're missing. That didn't make sense to me at first, but it certainly does after I gave it some consideration. Just to review the difference between a PSG and a home sleep test, I'll talk about the PSG or polysomnogram. Remember, this is usually done in a sleep lab, sometimes in hospitals, sometimes standalone sleep labs. You're going to order a baseline PSG to evaluate suspicion of sleep disordered breathing. Sleep disordered breathing is kind of the umbrella that encompasses snoring, upper airway resistance, and obstructive sleep apnea. Once they come back from this test, you're going to have a diagnosis. It's important to involve the patient's primary care physician, and whatever treatment we do, you need to get your letter of medical necessity, a prescription from them, not only to get insurance coverage many times, but also medically, legally, and just the right thing to do. It's the physician's, the quarterback in this case, primary care physician that is, and we need to involve them in whatever we're doing, because it is, in fact, their patient. You want to talk about the difference with the home sleep test, Rich?
You bet. Now, if you have one of these units, and I would highly recommend that as a dentist you purchase one. There are a bunch of good ones on the market out there. I know in our franchise we're using 3 or 4 more than we are others, and we'll be glad to share some of that with you if you email us. But if you have one of these units, don't be afraid to send a patient home with it. You're screening them in their practice. They're getting their teeth cleaned. How you sleeping these days? Are you tired? Oh yeah, my wife kicked me out of the bedroom for snoring. Well, we just got this new machine. We can send it home. We can do that. You can do all of this type of thing. And again, we want to involve the patient's physician. We don't want to be this rogue out there who's doing this and making these diagnoses on our own as dentists. So there are services out there that when you do a home sleep test, you can upload that data from that home sleep test into this cloud out there and have that particular study scored and interpreted and read by a board-certified sleep physician. You can get a diagnosis that way. Now, we do that in my practice routinely, but we also involve the patient's primary care physician when we do that. So when that comes back and we have a diagnosis, we instigate something with the primary care physician at that point and say, look, this patient is a mutual patient. We suspected they might have a problem. We sent them home with this FDA-approved level 3 home sleep testing device, and it was read by a board-certified sleep doc, and this is the diagnosis that came back. This is what we would like to do, but we'd like to involve you in how we do this. So just remember that there are guidelines and sidelines to this and how we do it.
I agree with everything you're saying. I do say that after you've developed relationships locally, it's often nice. You can usually find someone locally to work with you and your home sleep test, as I've done, and we've helped our franchisees get relationships locally to have someone read the test. But bottom line is get the test read. One thing that should be mentioned, if you're a Medicare provider, being a non-participating or participating provider, there's some guidelines against dentists using home sleep testing devices, and basically we shouldn't use them on our Medicare patients if we are Medicare providers.
Good point. And the idea there, of course, is they're trying to separate being able to profit from both the diagnosis and the treatment, right, which is exactly what happened through CPAP.
I think that's a big cloud. Sometimes people get, or that's a bit cloudy, I should say. People were kind of get caught up in what is the ruling here. And if you just remember what we say here, you can't benefit from the testing and the treatment on Medicare patients. So you can't profit and make money on the diagnosis and then also on the treatment. That'll keep you somewhat out of trouble with the Stark and the anti-kickback laws, although you should read those for yourself. Bottom line is just don't use home sleep testing on your Medicare patients if you're a Medicare provider.
Very good. And the bottom line is we want to educate our patients too. Think about you going in to see a doctor. You don't know that much about this. I really like to see doctors who inform me of my treatment options. And, before we're tested. So patients understand, what are my options? Well, you can take this home. You can do this. This is a more accurate test. You can do this and that and all those other types of things. And we mentioned the Medicare thing. But in general, inform your patients, encourage them to participate in their treatment and what types of decisions they make.
One thing that's key on that, too, is we as dentists are used to doing this. The medical world is not as good at this as we are. And you will find that the patients will be very appreciative of your time as well as of your knowledge if you just take the time to sit down and go over both options for testing and then options for treatment down the road. They don't normally get that on a routine basis in the detail that us as dentists are used to explaining to them. And therefore, they're going to really be appreciative of your efforts and more likely to do treatment with you because you've taken the time to go over the pros and cons, risk, benefits, and alternatives of all treatments out there. What happens if you don't have a home sleep testing device? Well, then the obvious thing is you can refer them to the lab for a PSG. You can buy a home sleep testing device, and now there's also labs and physicians who have home sleep testing devices. So that's really your options. I think if you're going to be involved with this on a daily basis and treating your patients, having some sort of home sleep testing devices, I won't say mandatory, but pretty close to mandatory because they're just invaluable for also titrating your appliances, screening your patients. It's much like the analogy we already used. If you're going to be doing endo, you need to be able to take an x-ray. If you're going to be doing treatment of sleep apnea with dental devices, then you really ought to have some sort of a home sleep testing device.
So does it really matter to you, Guy? Does it matter if we're doing a home sleep test or a full sleep test? If a patient asks you that, does it really matter?
It doesn't matter to me because we're not in the home sleep testing or the sleep testing in general business. We hopefully are in the business of caring for our patients, identifying that huge number of patients that are in our practices and in the general public who are walking around with undiagnosed, untreated obstructive sleep apnea or other sleep disorder breathing problems. We just want to get them tested so that we can get them treatment. And sometimes that treatment's a CPAP. Sometimes it's a dental device. But our goal is to get them tested. I really don't care how they get tested. I shouldn't say that callously. I mean, I care that they get tested. The mechanism by which they get tested is not really important to me. I just want them to get tested and find out what they have. And if they have a problem, seek some form of treatment.
And where did this I love your little tagline there, PSG or suicide bomber. Yeah, who knows? PSGs, there is a barrier to entry, though, and that's one of the things that we want you all to understand is that when somebody says, I'm tired, I'm sleepy, I have high blood pressure, and their primary care doc says, you know what, you should really go get a sleep study. Well, we need to understand that as dentists, that most of those patients don't go get that sleep test.
That's a very good point. When you asked me a moment ago, do I care? No, I don't care. But again, I care that they get tested. And prior to home sleep testing being available, and I'm a little different than you. I've been doing this as long as you have, but I've also been running a general dental office until recently. Getting my patients that came in to get their teeth cleaned, let's say they're in for hygiene, and we're just convinced they have a problem, and we convince them that they should get a test. They tell me, yes, I'll go. And, 4 months goes by, they come back for the recall and they never went. And I track a lot of numbers in my practice. I'm just really big on that. And that's one of the things I think we bring to the table of helping people understanding what their numbers should be and so forth. And prior to home sleep testing, I could only get about 1 out of 3 patients to go on at least first attempt at getting them to go. It would take several appointments before I could get them to actually go get the PSG. With home sleep testing, it's darn near 100%. They can't hardly say no to that. I have the equipment right there. We hand it to them. So I think
that's
that
a
is
good point.
Key.
What do you do about cost, Guy? We've got a question coming in here now that says, do you charge? Can you charge for home sleep testing?
I've been all over the board on that one. You can get some insurance coverage. Used to be for this. It's less than it has been. It's a lot of hassle. And again, keep in mind, I'm not in the sleep testing business. I'm in the business of helping patients get diagnosed, but then hopefully treating them with a mandibular advancement device. So currently, we have 2 methods of doing it. One is we just ask the patient to pay us if we're going to send it to a board-certified sleep physician so that to be read, which is in my office the majority of the time. I just prefer to go ahead and have the board-certified sleep physician read it. So I tell the patients there's a certain amount we take what the board-certified sleep physician or the service will charge us and maybe add a little bit in for our time and effort and tell the patient, here's the amount to have the sleep test to go get tested. Now, if a patient tells me, no, I just really don't think I have this problem, I don't want to do it, I'll do it next time or they put me off, then you know what I tell them, Rich? I say, Mr. Jones, I care enough about your health, and I would be remiss if I read in the paper that you died of a stroke next week, and I just didn't make you take this thing home. So look, if it's the money that's bothering you, I will pay the physician. Take this thing home. I beg of you, just take it home, and I'll fork out the money out of my own pocket because you've been a patient here for a while, and I care about your wife and family and you being around for them. So I'll pay the physician. Just take it home. And the neat thing about that is no one's taken me up on that offer yet. Most all the time, if you have that conversation, that they agree to go ahead and pay it.
Next time I'm in Florida, I'm going to take you up on that.
The other option is you can do it the way we discussed. You do the home sleep test and then discuss that with them and use the home sleep test. The way I would word that, and this is the way I used to do it prior to home sleep testing being legal. I would tell them, look, let's use the home sleep test and see what the computer tells us. I'm not making a diagnosis, and the computer comes in and we have the computer readout. And we say, look, it's telling us you're quitting breathing 20 times an hour. I'm really concerned. I'll be very surprised if you don't have sleep apnea. Let's go get you tested. So you can use it as ammunition for that reluctant patient. Again, keep in mind, we just want to get them tested. And having a home sleep testing device available really makes your chances of getting your patients of record tested on a more frequent basis.
Good point. Well, here's another question too that says, what does it cost to have these home sleep testing data sets interpreted? So in other words, what is the cost of actually doing this? If you have, and our next slide shows some of these level 3 recorders. So when you have one of these types of recorders, talk for a second, Guy, about what it actually costs to use it, because I know each device has some disposable things as well. And if we actually have that thing read, in other words, what are our hard costs as dentists if we actually wanted to do that and we did, the patient, let's say the patient did take us up on this and we were going to have to pay for it, what would we have to pay?
That's a very good question. First of all, there's 2 costs involved. Other than the cost of the equipment itself, you can look into those. You got to buy the piece of equipment. But once you own the home sleep testing device, Some of them, it costs every time you use it, whether you get a interpretation and diagnosis from a physician or not. The one on the top left of your screen, the watch pat, a very convenient mechanism that you can use because it just goes on your finger. But even if you don't get that interpreted, I think it's around $75 every time you use that. So if you're using it for titration, for adjustment of your appliances, every time you turn that on and send it home, it's going to have a cost associated with it. Same thing with the one on the bottom right, which is kind of the older version of the Watermark Aries, I think, out there. You've got to send it to them to get your data back. So those have a cost whether you get it interpreted or not. Some of the other ones like the Embleta, Stardust there, the Rimmers, also the Metabyte, they don't have a cost associated with using it. You download it to the software that comes with it. It self-scores it. And the cost is, under $10. It's the cost of a couple of batteries and a nasal cannula. So the first cost is using the machine. Some of them have under $10. Some of them are substantially more than $10. If you want a board-certified sleep physician to read that, and you want to use one of the companies that's already out there and up and running instead of doing it yourself, those costs can run from around $60, $59 I think is about the least, to $125 on some of the other ranges. I think somewhere between $60 and $125 to.
So if we put those things together, you got to buy the machine first. But once you have the machine, and those costs range from a couple thousand, $2,000 to $6,000, somewhere in that range. Okay, just give you a ballpark idea. Then the most that you would have to come up with out of pocket would be about $75 on the disposable side of that, and about $120. So you're still looking at under $200 of hard cost involved with that, and it could be certainly less if you use other types of machines.
Correct. I think that's a very good range of what it is. So it's not that much money. You've got a lot of equipment in your office that you spend more money and cost more than this. And if you're going to do this, you need to look at getting one of these devices. Be aware that they need to be a level 3. They're not all approved for diagnosis, although most of them are. You want to talk about how well these things work, Rich?
The technology is getting better and better all the time. But when we look at these validation studies and we look at sensitivity and specificity and all these, take you back to your statistics class in college. And man, that's enough to make my blood pressure go up right there. I didn't like that class. But anyway, you see these plots. And, when you look at the likelihood that you're going to send somebody home with a home sleep test and it's going to substantiate the same thing that a full polysomnogram would do, the machines are getting better, the technology is getting better, the algorithms that are actually being used inside of those self-scored, auto-score types of programs that these people use is all getting better. So the technology is there, the cost is coming down, and it's certainly a tool that we should be utilizing in our bag. Absolutely.
I think two key points on this slide, too, to look at. If you look, the numbers at the bottom are the PSG AHI, and if you look, no matter which machine we're testing, as you get less than an AHI of 20, 25, or 30, or certainly down in the 10, 15 range, see how they're more accurate the less severe the apnea is. So when you get a diagnosis and it's down in that range, they all seem to do a pretty good job of less severe. When you get real severe apnea, it's not quite as accurate in compared to the PSG. The other point is we're comparing this to the PSG like the PSG is infallible, and understanding patients don't sleep properly when they're taking the PSG at times, and it's not a perfect test either. None of these are perfect, but we certainly get an idea with either one of them how well a person is breathing at night.
Good point. Good point. And we don't want to split hairs here. We're not trying to make enemies of people who own sleep labs or people who manufacture home sleep testing devices. We want to care for our patients. We want to get them tested. So remember with the PSG, though, the next slide is that it is a more accurate test in general. I think most people would argue that. And we want to consider our patient and their best interest. What would be best for them? That comes back to, well, how sick are they? Are they young and otherwise healthy? Are they a little older and a little more sick? Involve the patient's physician, and remember that there is a higher barrier to that. So if we have that home sleep testing device, we have that in our back pocket, we're more likely to get somebody tested. So the next slide goes right into the home sleep test, and it's almost the corollary of each one of those. Same thing, involve the patient's doctor. Let's just get them tested. That's the bottom line. And involve their physician in helping decide which would be the best test.
Yeah, and oftentimes the patient will have an opinion on it. Let them choose. And key for me, someone who has a lot of comorbidities, in particular insomnia, other sleep problems. We're not really sure it's apnea that's causing them to be sleepy. Then we'd certainly need the EEGs associated with the PSG to see what's going on there. Bottom line, again, get them tested. All right, back to our slide here about patients presenting at the office and which way to go. Anything more you want to add on that, Rich?
No, but, understand that there are lines that go left and right and, up and down and those types of things. So this is just a good overview. As you learn more about this and you figure out how people plug into this system and do that, again, we want to keep the patient's best interest at heart. So let's move on.
What kind of diagnosis are you going to get with your patients? Well, I think we've got them pretty much all listed here. If the patient doesn't basically have any other form of sleep disorder breathing, they're going to get a diagnosis of primary snoring, which means that they just snore. They don't have the further things down on the list. Upper airway resistance syndrome, that's kind of a controversial subject. To technically measure it, you're supposed to have a esophageal pressure tube to measure changes in the airway. That's not often the way it's done. Most of the time, people who don't qualify for the further down the list OSA diagnosis often get put into the upper airway resistance category. Mild OSA, that's again 5 to 15, AHI 15 to 30 is moderate. Above 30 is usually considered severe. And someone who has central sleep apnea, in other words, they're not trying to breathe. It's not an obstructive event. That's not near as common as obstructive sleep apnea, but you may see on occasion someone who has primarily central sleep apnea, which we are not going to be able to help those patients because it's not an obstructive problem. I just hit on this a moment ago. There's the numbers again, between 5 and 30 AHI.
We're talking about the different diagnoses that patients are coming back with, and these are our recommendations for protocols for how you're going to handle this in your practice. So when they come back and they just have primary snoring, we can always consider positional therapy. In other words, I got the elbow last night, roll over. I snore on my back. I don't snore at all on my side. Weight loss. How many people out there can honestly say that they don't need to lose weight? Not that many. So it's a big problem. Alcohol. I had a patient the other day. Do you drink? Well, a little bit. I mean, I have a couple of glasses of wine. And her husband says, yeah, but a bottle of wine only fills up 2 of your glasses. So she was drinking a bottle of wine every night before she went to bed. And obviously that has some effect. So do we really want to use CPAP in an instance like this? I mean, I've been doing this a long time. I can't find a study out there. If anybody knows of one, I would love you to email it to me, that shows that CPAP effectively treats mild sleep apnea. And snoring is certainly less in severity than mild sleep apnea. So these are great people to use a dental device on. If we've gone through the testing protocols that we've talked about, then we have a very good idea of what we're treating. And lastly, we want to say that insurance coverage is just about 0 on this, unless somebody has a very private, high executive kind of guy that has some kind of insurance that pays for everything, then they're not going to pay for it. So moving on next in this continuum of diagnoses, we have upper airway resistance syndrome. Why don't you talk about how you treat that guy?
Pretty much the same, except for a dental appliance might be moved up a little bit in this scenario. Typically, these are the patients who are sleepy snorers. They have a low AHI and a high RDI. So pretty much the same thing. I think a CPAP would be down on the list. All the other things would be above it. Insurance coverage. You might get insurance coverage if they have an Epworth sleepiness score that's high enough, if they also have high blood pressure or some other comorbidities, but insurance coverage is possible but sketchy on these patients. If you do have home sleep testing devices, oftentimes you can look at things called resisted breaths, or they call them various things with different home sleep testing devices, and that's a good way to see how well you're treating these patients. These are airflows that aren't causing apneas and hypopneas, but are still causing disturbance in sleep. And they can be very sleepy, and they respond very well to dental appliances. I find these to be some of the best patients.
And next, we move in this continuum to mild OSA. And remember that these aren't necessarily listed in the order that we would say, hey, you should have this done. But they're certainly done from the easiest standpoint. In other words, if somebody has mild sleep apnea and their sleep test comes back and it's a polysomnogram and it says their AHI on their back was 5.8. We know 5 to 15 is mild sleep apnea, and their AHI on their side, and they spent 3 hours on their side, was 0. If I'm a patient, would like to know that if I just stay off my back, then I can treat that way. So those are the types of things that you want to be thinking about as you look through the testing and those types of things. Again, weight loss, dental devices. You heard what I said about CPAP earlier. We really, really want to push our devices on mild sleep apnea. The studies out there show that we are the most successful in treating this group of patients, and we want to make sure that they understand that as well.
If I had a bone to pick with the medical community at large, it would be that these mild patients are routinely given CPAP as their only and first line of therapy for mild OSA. And I truly believe from my experience and the literature that dental appliances should be the first choice for these patients. And that's gradually changing. I think with the help of the other dentists on this webinar tonight and us involving more people in our franchise, we're changing that. Dentists should really be on the forefront of most people's mind when it comes to mild obstructive sleep apnea.
Now, what about, when you say that, then we have mild, moderate, and severe, of course, in our continuum here. I think it's probably fair to say that severe should get CPAP first, mild should get dental devices first, and then, of course, that puts us in the middle, which is next.
Yeah, and there's always gray areas in everything. And moderate OSA, I can go either way depending on the patient. I don't think that the system that we have to place people into a category is ideal. It basically just takes the events per hour. It doesn't take into comorbidities. It doesn't take into consideration how low their oxygen was going down, how long it was staying down, other symptoms. So this is something that probably can't explain in a webinar. Experience comes into play. But if you have a moderate person, AHI of 20, their only really complaint was that they snored, they don't have a whole lot of other problems, I think they're a great candidate for a dental appliance. The other person who has fibromyalgia, chronic fatigue, sleepy, high blood pressure, had a stroke, and their AHI is 20, and maybe their oxygen went down into the low 80s, I think they're probably a better candidate for CPAP. So those are pretty obvious. There's gray areas in between. So all moderate apneics are not the same, I guess would be the thought there. And I see the note says anatomical parameters. Some people respond better to dental appliances, people who are retrognathic, long lower face height, not obese patients. So that would maybe push me in the direction of a dental appliance too. You have anything to add on that, Rich?
No, that's excellent. Excellent. I'm glad you brought all of those points up. And again, that I think severe should have CPAP offered first. Mild can go either way, but certainly we want to push the dental devices. And then there's a lot of in between there. But that gets us to severe. And the guidelines from the American Academy of Sleep Medicine say that they should be given CPAP as a first line of option. And that's certainly true. And we know that a lot of people simply won't use CPAP. If they're severe and there was enough data during that initial study, then they probably tried to titrate CPAP during that initial study, under a split-night study. So patients will have some experience with that, the majority of them already who have been tested in a laboratory type of testing facility. But we need to remember, too, that we can still use a dental device on these people. And we also have hybrid therapy, which we've not talked a lot about, but that's where we can use a dental device and CPAP, and that's a whole new field. Keith Thornton has probably done the most work in this with his TAP-PAP and those types of things, and we certainly want to make sure that we as dentists know what all of these options are and that we educate ourselves. I mean, you mentioned some things, Guy, about moderate sleep apnea and how if a patient has the same AHI, but they're really not the same. Those are the types of things that you'll pick up on as you read more about this and you study it more. So consider the patient. Weight loss is always in there too. Disease severity. And again, there are lots of things that go into this, and we can certainly get some help from our physician colleagues as well.
Two things I would add on that would be that to reemphasize, no matter how severe they are, if they won't wear their CPAP or refuse to try a CPAP or just can't deal with the CPAP, then you should go ahead and treat them. There's not a number where I won't say, look, we can't help them, because we almost always improve them. Not always, but almost always. We make significant differences. And then including then the hybrid therapy, you can really make the CPAP very tolerable with, like you said, lowering the pressures, the TAP-PAP, the OPAPs out there now. So those are two key things. Don't be afraid of the severe apneas as long as they've given due diligence to the CPAP.
So where can we learn some more about this, Guy?
Well, in the past, we've given you some journals and some specific articles, but I've learned as much from other physicians, from dentists, from manufacturers. I mean, these people who sell like home sleep testing devices, they can teach you how to use their equipment. Lots of them have been in the sleep industry way longer than Rich or I have. So I think this time we'll emphasize that you can learn a lot from a lot of different people. Certainly the journals are great, but read all you can and do as much as you can and start talking to your physicians. You'll find a lot of them are open, are willing to educate you. Spend time in a sleep lab. Ask them if you can visit. Sit down and spend the day or the evening with a polysomnograph technician and have them explain to you what they're doing and why. Those are the types of things that'll stick with you, maybe even more so than some of the other literature that we've asked you to look into in the past. Also, we're going to have a slide for it coming up. Again, the course we're giving in Texas, you can't get a much better deal than it for $95. Before we do that, let's talk a moment about the Keller webinar special.
If you contact Keller, they've helped us get this whole webinar series together and all of this, and we've teamed up with them. And we like these people here. They really seem to do a good job. For $49, you get a bunch of things. You get a sample EMA device. You get a waiting room DVD that talks about the TAP. They'll give you TAP and EMA brochures. They give you the Epworth Sleepiness Scale, as well as coupons for your next case. And they'll even throw in a sample letter of medical necessity, which is something that we'll talk more about in our last webinar when we talk about getting insurance coverage. But you can email Keller at kellerlab.com, and they will be glad to get all of this stuff to you. Okay, we also want to tell you all about something going on in my hometown, San Antonio, Texas, October 7th. You see the picture of the Alamo there. It's a full day course for just $95 for a dentist. We don't know anybody else out there.
Are you kidding me? Are you kidding me? You hear that saying all the time, but I have to really say that $95 to have a full day of hands-on education. I don't know of anybody who's ever put on a course, dental sleep in particular, for that amount of money. San Antonio's real nice that time of year too. I was there a few times, and it's a great place to visit, isn't it?
Yeah, we got the Riverwalk downtown, and it's a neat place. Make a trip out of it and bring your wife and your husband and your office manager, whatever. It's only $45 for staff too. So I'm going to do that course, and I'm going to do the first half. We'll do dental sleep medicine, and the second half we're going to do implementation type things. What it takes to actually start doing this in your practice. I'll have some sample devices there that you guys can look at and see, and we'll talk about which appliances to use on which types of patients and things like that. So it's a great opportunity to get a full day of CE for just $95, and we really encourage you guys to register at info@dentalsleepsolutions.com.
Well, again, you can't beat that for $95. What are we going to do next? Well, we have a couple more webinars coming up. October 12th, we're going to talk about titrating dental devices and managing side effects, which, we've got all people ready to start doing these things. We got to help you with some problems that you may come across along the way. And November 9th is practice marketing and medical insurance billing. You've got to get paid if we want to do these things. So those two will finish out our 6-part webinar series. If you're signed up for this webinar, you're signed up for all 6. Don't forget the in-person course on October 7th. Also, remember our franchise. If anybody really says this is what I want to do, feel free to email me, Dr. Yatros at dentalsleepsolutions.com or Dr. Drake at dentalsleepsolutions.com, and we can certainly answer your questions about how we can help you get rapidly involved in this. Again, remember to get your credit, to answer the questions answer your email and then answer the 10-question quiz, and we will get your CE verification out to you. I want to thank everybody again for attending. This is the upcoming course information as well as the webinar information. Do we have any time for any questions, Rich? I know that we've got a few coming in and we're almost over here.
Yeah, we've already gone over a little bit. We're about at that time, and we'll get some more of these in next time. And you guys can certainly email us, and I'll get you answers to your questions that you've put in here too. And again, we appreciate your time tonight, and thanks for tuning in, and we hope to see you next month. Thanks again, guys.
Thanks. All right. Good night.